Good morning, everybody. Welcome back to this Journal Club session. It's delighted today to welcome Francesco Spione from Hospital Clinic in Barcelona, and a very warm welcome to Professor Salvatore Brugaletta, also from Hospital Clinic Barcelona. Today, we'll be discussing quite an interesting topic, which is that of post-infarction mitral regurgitation, perhaps a scenario that we do not see so often in our clinical practice, but when we do, can often be quite dramatic. So this is a very nice study discussing all the different management options. And so looking forward to the discussion. If you have any questions, please do type them in the chat, or we will address them at the end of the session. So Francesco, can I invite you please to share your screen? And as you're doing that, we can have a look at the poll, which will run for another few seconds. So the question we're asking today is just to understand from all of you fellows connected, which of the following treatment strategies have you experienced for treating acute post-infarct severe mitral regurgitation? And it seems the majority of people are familiar with medical therapy. Very few people have come across surgical mitral valve replacement, only about a third of respondents, and about 50% are familiar with percutaneous mitral valve repair. So with that, let's start with the discussion. And Francesco, I'd invite you to start, please.
Can you see PowerPoint? Yeah?
Yes, working perfectly.
Perfect.
Okay.
Thank you, Ari, for the introduction, and good morning to everyone. So I'm going to present this article published on the European Heart about the conservative surgical and percutaneous treatment for mitral regurgitation shortly after acute myocardial infarction. So what we know about this complication, the mechanism that can cause this complication are two, papillar muscle rupture after the infarction, or leaflet tethering due to a regional wall motion abnormality. This complication can occur in the 12% of all patients with acute myocardial infarction that can present a moderate to severe mitral regurgitation at 30 days of follow-up. This complication has a high mortality rates with a rate of 24% at 30 days, 42% at 6 months, and 52% at 1 year. And the problem is that most of these patients have high surgery risk or are considered inoperable. So far, we don't have a lot of data about the percutaneous treatment of this complication after acute myocardial infarction. There are two registries that have been published. This one, the Israeli mitral clip registry, was published on JACC, and they included 20 patients with acute mitral regurgitation after STEMI with a median follow-up period of 15 months. And no patient died after 30 days of follow-up. And we can see here in the result how there was a significant reduction in the mitral regurgitation grade, with most of the patients with a mitral regurgitation grade from 1 to 2, and an improvement in the hemodynamic parameters like the left atrial wave and the pulmonary artery pressure, and also an improvement in the clinical presentation of the patient at follow-up. The other registry is the RME registry that was published on neurointervention. 44 patients with acute mitral regurgitation after STEMI were included. Technical success was obtained in 86.6% of cases with a median of 2 clips per case, and the median length of stay of patient after the procedure was 16 days. Also here in the result, we can see at 6 months of follow-up, we have a significant reduction in the mitral regurgitation grade, with most of the patients with mitral regurgitation grade from 1 to 2, and an improvement in the clinical presentation with most of the patients in class 2 NIA. And about the outcomes, death occur at 30 days for death, and 6 months 8. The readmission due to heart failure were 8 at 6 months, and just 4 patients underwent surgery after the procedure. And the major adverse events were 5 at 30 days and 16 at 6 months. So about the study that I'm presenting, the objective was to compare the outcomes of patients with acute mitral regurgitation after MI that were treated conservatively, surgically, and percutaneously. This was a retrospective international registry of consecutive patients with at least moderate to severe mitral regurgitation following MI. It was a multi-center registry that included 21 centers in North America, Europe, and the Middle East. And the registry included all patients that were treated conservatively and those having surgical mitral valve repair or replacement or percutaneous mitral valve repair using mitral clip system. What are the inclusion and exclusion criteria? All patients with at least symptomatic mitral regurgitation grade 3 or more after optical medical treatment within 90 days after acute myocardial infarction in the period between December 2009 and March 2020, and that were treated with surgical mitral intervention percutaneously or conservatively. And in this analysis were excluded all the patients with papillary muscle rupture. About the echocardiographic evaluation, significant mitral regurgitation was considered as grade 3 or more. Mitral regurgitation mechanism was evaluated and classified as primary mechanically papillary muscle rupture or secondary mitral regurgitation. The surgical intervention was considered successful when there was a reduction of the mitral regurgitation grade 2 or less, and a successful weaning from cardiopulmonary bypass. And the percutaneous intervention was considered successful when there was a reduction in the mitral regurgitation grade 2 or less. The endpoints. The primary endpoint was in-hospital, all-cause mortality, and the secondary endpoints were immediate procedural success, 1-year mortality, echocardiographic outcomes evaluated with mitral regurgitation grade and the pulmonary artery pressure, clinical outcomes evaluated with the New York Heart Association class, and safety outcomes included procedural and periprocedural complications. Major procedural complications were defined as myocardial infarction, stroke, cardiac tamponade, reintervention for adverse events or failed procedure, renal failure requiring renal replacement therapy, septicemia, or transfusion of 2 or more blood units after the procedure. The statistical analysis compared conservative group versus the intervention group and the 2 intervention groups, so the surgical group versus the percutaneous group. A second analysis was done, excluding patients who died in hospital and in subgroups according to patient median ERO score 2. Kaplan-Meier estimates were used to calculate survival curves, which were compared using the long rank test 1-year mortality. Univariate and multivariable logistic regression method were used for the primary outcome using a myriad of clinically significant cofactors. Univariate Cox regression model for 1-year mortality using potential predictor, and those found to be significant in the univariate model were included in a subsequent multivariable model. To further validate findings, the investigator realized also a propensity score matching in order to create 2 groups with similar baseline characteristics. And in-hospital mortality was compared between groups using the McNemar's test or the Fisher-Exact test if not applicable. Then, also stratified Cox regression was used to study the association between type of treatment and 1-year mortality. So the study flowchart. The registry inclusion criteria were all capable centers to perform percutaneous mitral valve repair and surgical mitral valve repair, significant mitral regurgitation that occur within 90 days after the acute event, and all patients that were symptomatic despite optical medical therapy. So the total registry population included 517 patients and were excluded 46 that had papillary muscle rupture. At the end, the total study population included 471 patients, 266 were treated conservatively, and 205 with interventional treatment, 106 with surgery, and 99 with percutaneous treatment. Looking at the baseline characteristics, if we focused on the interventional group, we can see how the group treated with the percutaneous intervention these patients were older. They have more frequently a history of prior MI or prior CABG, and they had worse presentation at the admission with STEMI presentation, cardiogenic shock, or need of mechanic ventilation. Then, about the procedural details and patient outcomes between the two interventional groups, we can see how patients that were treated with percutaneous mitral valve repair were clinically worse, but surgical repair was performed earlier, with median days from the acute event to the procedure of 12 in the surgical group and 19 in the percutaneous group. Immediate procedural success was high in both interventional group, with success of 92% in the surgical group and 93% in the percutaneous group. And but peri-procedural major complication rates were significantly higher in the surgical group. Looking at the outcomes, in-hospital mortality was significantly higher in the conservative group, reaching the 27%. And looking at the two interventional group, we can see how in-hospital mortality and 1 year mortality was significantly higher in the surgical group. If we look at the procedural outcomes, we can see how there was a significant reduction in the mitral regurgitation grade, both in the two groups, in the surgical group and the interventional group, with the majority of patients that discharged with mitral regurgitation grade of 0-1 in the surgical group and from 0 to 2 in the percutaneous group. There was also a significant improvement in the clinical presentation, with the majority of patients with NIA class from 1 to 2. And there was also a significant improvement in the hemodynamic parameters, especially in the pulmonary artery pressure, where there was a significant reduction in the percutaneous group. Looking at the mortality analysis, the most interesting findings are that there is a significant difference between the conservative group and the interventional group, with a higher rate of death in patients that were treated conservatively. Then the investigator also performed an analysis between the two interventional groups, and it was finding that there was a significant higher rate of death in the surgical group. Then they decided to perform an analysis excluding all patients that died in hospital, and there wasn't a significant difference between the two interventional groups. And then there was also performed an analysis between the, according to the median Euroscore 2, and there was a patient with low Euroscore were considered those who had Euroscore low than 10 and high Euroscore more than 10. And there was a significant difference, especially between the two low score group with a value of P of 0.05. Then there was also calculated the 1 year mortality predictors in this group of patients, and predictors that were significant at the multivariable model were age, high Euroscore, a Philip-Kassa presentation more than 3, and the need of any mechanical circulation support and any intervention after the first procedure. Of course, the study has a lot of limitations. First of all, it is a retrospective analysis of data from several centers, and it was conducted over a longer period of time, like 11 years. And despite multivariable adjustment and propensity score matching, the association between baseline characteristics and outcomes may be confounded by unmeasured variables. Patient allocation to each therapy may be biased due to clinical factors that affected physician decision-making. Laboratory data, medication, detailed and core lab echocardiographic evaluation is lacking, so it has not been evaluated the effect of the procedure on left ventricular remodeling. It is a proof of concept studies, and the percutaneous repairment were performed at highly experienced centers, and in all cases, this was performed as a salvage procedure in critically ill patients. Finally, this finding also cannot be generalized for mildly symptomatic patients who develop ischemic mitral regurgitation after MI. So, what are the conclusions? Post-MI severe mitral regurgitation is associated with poor outcomes. Patients were often in extreme clinical condition, but intervention, both surgical and percutaneous, resulted in favorable outcomes when compared with a conservative treatment. And percutaneous mitral valve repair was successful in decreasing mitral regurgitation and improved hemodynamic parameters and also clinical presentation, and should be considered as an alternative for patients that are deemed high risk for surgical intervention. Thank you for your attention.
Great. Thank you, Francesco. Very nice summary and a great presentation. So really great stuff. Professor, can I please invite you now to give us your insights into this trial and also this field? How does this fit into this field? And afterwards, if anybody has any questions, please do feel free to come on and we can discuss them together.
Yes. First of all, I would like to thank you for the kind invitation to this journal club, so which I am follower. So during the Friday morning. So this study, I guess, so is the best evidence that we may have today. So according to this topic, so to mitral regurgitation, in the sense that it will be impossible to make a randomized trial. So comparing patient with mitral regurgitation, so randomized to these three different treatments. So to me, so it's the best evidence that we may have. However, so there are many limitations, so especially in the methodological part, that I would like, to give to you, because so the conclusion that we may take from this trial is that every time that we see in a clinical practice a patient with a mitral regurgitation, so it will be better to make an edge-to-edge correction of this mitral regurgitation. But that is actually not the message of this study. So the study is just saying that if we have a patient with a specific clinical and also anatomical characteristics, so if the patient goes to one of these three treatments, so may have higher mortality, but that doesn't mean that if we have a patient, we have to go to the treatment with less mortality. So I guess that, so having said that, so let's try, to look at the specific methodological limitation of this paper, which to me are important. So first of all, so is the data quality. So as Francesco said, so this study has been done during 11 years, so it's a lot of time. So we have to look back to 11 years ago, so to take the data of the patient that we were treated 11 years ago, and there are actually no, so there is no check on the data quality. So we don't know how these data were collected. So there is not even a CRO which is looking at the data that are corrected, taken from the technical history to the patient and then translated to the Excel. I guess that was used for the study. Then, so we don't have any event adjudication. I guess that for all cause mortality, so we don't need any event adjudication because it's quite easy to say if the patient is died or not. But for example, so when we look at other parameters, like for example the NIA class, or the rehospitalization, or for example, the improving in the mitral regurgitation. So we need at least some adjudication, so in some sense, because you know that the NIA class is very subjective, and so if someone is more prone to the surgical part or to the clinical part, so may give less NIA class, so according to the treatment, because so everyone is not blinded so to what was the treatment. But anyhow, so all cause death is very reproducible, so we just have to look at that. Especially, I mean, if we look at the improvement of the NIA class, so there is a selection, so in the patient that reach the 30 days follow-up, because we eliminated those patients who died. So we have, of course, an improvement in NIA class, but that is maybe because some patients, so the worst patient that died. So then, so the really most important is about anatomical eligibility, because although we have seen several characteristics which are different in terms of age, of baseline clinical factors, etc. So it's impossible, I mean, to compensate for anatomical eligibility of this patient for any of these three treatments, because of course, so there are some characteristics for the mitral clip treatment which cannot be treated. Like, for example, so if we have a white cooptation, so that is something which cannot be treated with a mitral clip. And on the other side is if we have a specific surgical scenario, so that should be surgical treated and not with a mitral clip. So there are some anatomical eligibility which are not being taken into account, because again, so it is impossible. So, but this is not a randomized comparison, and so it should be taken, should be considered. So then something which also surprising me is that at the beginning, so we say that mitral regurgitation is after an acute ST elevation MI. But then, so if you look specifically at the patients that are being included, so only, if I remember correctly, only 40% of the patient are with a ST elevation. So that means that the cause of this mitral regurgitation is not most of the time. So, for example, a rupture in the chorda of the mitral valve. So we know that the rupture of the muscular papilla has been already taken out from this registry. But so we should consider that so not all these mitral regurgitation are because of the ST elevation. So it could be, for example, any kind of any ACS. It can be also the case of a patient with a long history of ischemic heart disease that at some point have made some non-ST elevation MI. So we don't have, for example, any PCI, because PCI is not done in 100% of the patient. And then we see that if we have a mitral regurgitation, which is maybe a mixed mechanism, so it's not only ischemic, but it could be also degenerative. And finally, so there are 2 points. So one is from the statistical part. So I'm not a statistician, so I guess that you, as younger than me, so I'm not older, but you are, of course, younger than me, so you know better than me than statistics. So I wonder, so about the additional value of propensity score. So in this study, on the top of the multivariate Cox regression analysis, no, because the propensity score, so in the multivariate Cox, so to me in this case, are looking more or less at the same. So to me, the propensity score is maybe so it could be removed from the paper, because so if we are already correcting in the Cox, so the mortality for the differences in the clinical variables, so that is to me already enough. So we don't need, I mean, to make a propensity score, because the propensity score is just reducing our sample from around 100 to 38, and we are comparing 38 patients per arm. So this is not a randomized trial. This is not going to give us a final answer, because we are talking about 38 patients. And to me, propensity score so should be done so only if we have big numbers, like, for example, 2,000 patients per group. And in that case, so we are comparing something, no? But if we are doing just this propensity score on the top of the Cox, that is something that so is not going, I mean, to add a value to our analysis. And finally, my last comment is about medical treatment. So a medical treatment is totally missing. So because we don't know, so what is going on with this patient after the discharge. So we don't know which was the medical treatment, even of those patients who received medical treatment. So we don't know. So I guess, so it will be more or less the same. So in terms of ACE inhibitors, diuretics, beta blockers, etc. But actually no data have been produced on this part, which is important because at the end the title of the paper says medical treatment, surgical and percutaneous. So we need at least data about the medical treatment. And then, so I guess it is done. So I don't know, I mean, if there are any questions from you, from anyone here.
Yeah, so first of all, thank you. It's great for all of us young fellows to have such a detailed analysis and a deep dive. So let's start with some questions. So Guido's asked a couple of questions. In the surgical arm, was it replacement or repair? And do they specify what they did? And then there's a second question about timing, which I'll ask afterwards.
Yeah, so that is a good question because that is also something which is missing. So we don't know which kind of intervention has been done. So I guess that as we are talking about a valve, so after an acute MI, so the answer should be a replacement because that is something which is very difficult to repair. So, and if we are going to repair the valve, so of course the percutaneous intervention is better than the surgical because you're just making a patch in the valve. So you're not. Okay, so we have 57% of repair and 43% of repair. Yeah, but so that is something, I mean, because to me, the replacement will be much better because so we are talking about a valve, so with something which has been ruptured. So we have to maybe reconstruct a cord, we have to reconstruct the annulus, but so the replacement will be a definite solution for this patient. And that was not done actually. So we see that we have 50-50.
Great. Thanks, Jonathan, for that rapid response. So the next question about timing. So there's one question is why was surgery done earlier than percutaneous treatment? And generally, what is the sort of time frame that we should look at for both referral for surgery or for, not to say mitral clip only, but just percutaneous edge-to-edge repair?
Yeah, so that it is a good question. So I don't have the answer because to my experience, and I don't know, I mean, for your experience, the surgical treatment is always arriving late. So especially to this patient, because if we are talking about patient with an acute, so mitral regurgitation because of an acute ST elevation, so the surgeon cannot operate very early because the tissue of the mitral valve or the tissue of the scar after the ST elevation MI, so may increase, so very huge, so the risk of the operation. So to me, it will be the other way around. So that is also something that we should consider when we read this paper. So it's something that is going, I mean, against our daily practice, where the surgical treatment is always offered late to the patient instead of the percutaneous repair.
Yeah, certainly. And then you commented about this, 11-year history of the data collection. Now, in those 11 years, a lot's happened. We've got an evolution in our imaging, evolution in our device technology, and obviously learning experience with edge-to-edge repair. So, how do you think things will influence that? Because somebody here, Vincenzo's asking a question about the future of edge-to-edge repair, and we've got newer devices, the portfolio is larger now. So what impact do you think this might have on both decision-making and maybe outcomes?
Yeah, that is an interesting point because as we say, so 11 years is a lot of time. So we used to have these 11 years. So when we have, for example, American registry, so having, for example, 10,000 patients, but in this case, we have not 10,000 patients, we have much less. And as you said, so the evolution of the medical treatment even, or the surgical treatment, so has been changed during 11 years. So it's not the same 11 years ago when we had a mitral regurgitation than here. Than today in terms of also mechanical devices, like for example something which can recover the ventricle. So it's totally different, and it's something that we have to take into account. So time, for example, so would have been a variable which should be inside the COX for correcting, time of an intervention where it was. But of course, so when we look at the future, so I guess that the TER is the future. So it can be more adopted in this patient, but when, so we have anatomical characteristics, because again, so I guess that the final message for all of you, because so we are cardiologists, residents, fellows, etc. So is that this paper is not saying that every time that we have a mitral regurgitation, we should go for that option, which has the less mortality, but it just says that if we have a patient that it goes on one arm or the other arm, the other ratio, the other risk of the patient, so is depending from the treatment. So every time that we have anatomical eligibility for mitral clip, we should go there because we know that the mortality will be less. But of course, there are some anatomical characteristics which cannot be treated. So the future will be for the year in this kind of patients. So maybe we also think about not only about primary PCI, but maybe primary mitral repair. So there could be, I mean, a possible field for the future. And let's see. So maybe we will talk, I mean, in 10 years from now. So when there will be more mitral repair done, so in the world, so with more numbers.
Great. So we're almost at time, everyone. So we'll just take a last couple of questions. Evelina raises a nice point, which might help to explain some of the disparity we see with timing of surgery versus percutaneous treatment. And it could be due to the need for myocardial revascularization. So the surgical arm, they went quick, revascularized, and then repaired the valve. Marco has a question about the Kaplan-Meier curves, which separate at 90 days. And how might we explain this, let's say, slightly delayed separation?
Yeah, the Kaplan-Meier actually, so they separate immediately after, so the discharge. Because for example, so I mean, I have the paper. I want to have a look. So if you look, so so we don't know actually the discharge days of these patients, you know. So we don't know how many days have been in the hospital. But if we remove so those patients with an in-hospital mortality, so we see that actually, so there is no divergence in the Kaplan-Meier. So I guess that it is 90 days, so it could be so still the result of the in-hospital mortality of this patient. So I guess that the time where we have to divide these curves is the in-hospital discharge of these patients. So when the patients are discharged, so there is no difference. But when the patients are still in the hospital, so we still have difference, and this is influencing the Kaplan-Meier curves.
Okay, and let's take a final question then. Alessandro, you have a question about edge-to-edge repair?
Yes, I would like to ask you, Professor Brugaletta, what do you think are the challenges that we're going to face when we approach a patient with acute MR with TEAR? It's a different setting from chronic MR. We will certainly have some different anatomical features.
I mean, the only anatomical feature which may be different is the size of the left atrium, because the left atrium so will not be enlarged as, for example, in chronic mitral regurgitation. So every time that we have to navigate inside the left atrium with the catheter, so maybe more challenges than with the chronic. But for the rest, so it will be more or less the same. So it will be maybe more difficult to fish, let's say, the mitral leaflets, because so they are with the so they move too much because of the acute mitral regurgitation, because of some cords are ruptured. But I guess that the most specific challenge is the size of the left atrium. And I guess, I mean, to answer the last question from Rossella, so that the future so will be so the mitral clip. So as I said, so we have now used it to have a primary PCI, and I guess that the future so we will have maybe mitral transcatheter edge to edge so a repair of the mitral clip in this specific setting.
Great. Okay, so we've just come to time. Thank you, everybody, for your participation and questions. Francesco, thank you for setting the scene with a brilliant presentation and summary of this article. And Prof, really, it was a wonderful session, short, brief, but I learned an awful lot, and really appreciate your deep analysis and deep dive into this topic and the paper. So thank you for joining us.
Thank you for the invitation.
Thank you. Thank you very much.